We will now start the second session, okay? It is a great pleasure to be with the eminent members of the EASD. My name is Professor Omar Sadani from Cairo University. The first speaker here will be Professor Mina. She will speak about hypoglycemic mechanisms and possibilities for prevention. And how can I prevent this hypoglycemia? Professor Mina is, of course, an eminent doctor from Greece, and she has special interests in diabetes and hypoglycemia. Okay.
Good afternoon, everybody. Thank you very much for the nice introduction, and thank you for the great hospitality and the excellent program that you have put together. Actually, my name is Mina Mitrakou. Mina is my first name, but it's nice. That shows that we are close friends. So my talk today is hypoglycemia, mechanisms and possibilities for prevention. As you all know, the brain is a very delicate organ that depends only on glucose in the circulation, cannot create glucose and cannot store glucose, so we have to be sure that the glucose levels are correct in the blood. And there are two sets of hormones that take care of that, insulin and the others. And when I say the others, I mean the counter-regulatory hormones, which are cortisol, norepinephrine, epinephrine, and growth hormone. Usually, we see hypoglycemia in the people we treat with insulin or any secretagogues because we leave them in many hours in hyperinsulinemia during the day due to the deficiency of the pharmacokinetics of the insulins that we were using up to now. What happens in a normal person, there is a hierarchy of responses in order to keep the blood glucose in normal values after the blood glucose is trying to fall below 70. And this hierarchy means that at levels around 60 to 68 to 69, when the glucose falls at that level, then you have the secretion of counter-regulatory hormones. Right after that, around the level of 60, you have the adrenergic symptoms, which are tremor, palpitations, anxiety, sweating, and these are the symptoms that tell you that your blood glucose is falling, so you have to do something not to let it fall any further. But if it does, then you get the neuroglycopenic symptoms around the level of 50 milligrams per dl, which means that your brain understands now that the blood glucose levels in the periphery are low. And if nothing happens there, if you don't take any precautions, then hypoglycemia evolves, and then you have levels of 40 and 30 and 20, and if they are for a long time, you may go to lethargy, coma, or convulsions. This thermometer was taken from these elegant studies we did back in Mayo Clinic with Professor Greee and other colleagues, where we brought normal people in the laboratory and we brought their blood glucose levels down from euglycemia 90 to 78, 65, 54, and 45, and as you see at the scale over there. Bringing down the blood glucose levels gradually, we would leave the people around 40 minutes at each level, because it takes about 20 to 25 minutes for the brain to understand the level of glucose in the periphery. And we were measuring hormones and symptoms and cognitive function. And this is how we saw that everything changes at a certain level. Actually, as you see at the bottom of the slide on your right-hand side, you see that even cognition changes during hypoglycemia at a level around 45 to 50 in normal people. Moreover, following the same design of studies, other people have looked at prior hypoglycemia in normal people. So if you create a hypoglycemic episode of around 60 milligrams per dl in a normal person, and you study him the next day with the design I showed you before, you see that they have decreased secretion of glucagon and epinephrine hormones, and they have less symptoms of hypoglycemia. And as our population grows older and our type 2 patients are older, we have to take care of what happens in older people. And in older people, normal people, you see a decrease of the symptoms during hypoglycemia, and actually they happen at a lower level. And not only that, these people get disturbances of cognition, so it takes them longer, as you see in the blue, to achieve the cognitive test than younger people. What happens in type 1 diabetes? Well, we treat diabetes type 1 intensively in order to avoid the complications of diabetes, but this has a result, a threefold increase of hypoglycemia in the intensively treated group. And let's see what happens in terms of physiology in people with type 1 diabetes. Early on, upon the diagnosis of diabetes, if you do an acute hypoglycemia in these people, they have the release of all the hormones, glucagon, adrenaline, noradrenaline, and cortisol. They don't have glucagon responses, right from the very first day of their diagnosis. And as the years go by, well, they lose the glucagon and half of the epinephrine in the beginning, but after 20 years of disease, they lose their epinephrine responses. So that makes it hard of them, if they don't have glucagon and epinephrine, if they get a hypoglycemic episode, to come back to euglycemia. Along the treatment of diabetes, along their life, you see that many patients with diabetes lose their adrenergic responses. So we have people who understand their hypoglycemia and people who do not feel their hypoglycemia. And if you study them with the same design, you find out that the people who do not understand their hypoglycemia, they have decreased norepinephrine and epinephrine responses, and of course they don't have glucagon from the beginning. So the thermometer becomes like that. You have everything moved down, which means that you get first the neuroglycopenic symptoms in a lower level than in a normal person. You get the adrenergic symptoms in a very, very lower level, almost at the same level that you got the cognitive dysfunction. And of course, you have decreased counterregulatory hormones, both in magnitude and at the level of glucose where they are secreted. And this phenomenon is related to diabetes relation and intensified control of diabetes. So putting it all together, you see that the intensive insulin therapy in people with type 1 diabetes, just because they have imperfect insulin substitution, we have a strict goal of normoglycemia, and they have deficient glucagon responses to hypoglycemia. That leads to mild recurrent hypoglycemia of levels around 60, which then impairs the secretion of adrenaline, and that leads to severe hypoglycemia, but also it leads to initial loss of symptoms, which is hypoglycemia and awareness. And if you don't understand your hypoglycemia, then you get more hypoglycemic episodes. It's a vicious cycle that leads to severe hypoglycemia. Is the phenomenon reversible? Early on, we studied this phenomenon, and we found that in people with insulinoma that are completely unaware, if you remove the insulinoma, then even within 1 week, they have complete restoration of their symptoms and the secretion of the hormones. The same phenomenon was studied in people with type 1 diabetes. This group took patients with type 1 diabetes who were unaware. They followed them up, relaxing their control without altering their hemoglobin A1C, but even if they alter it, it doesn't really matter for a short period of time. And they could see that even within 1 week, but of course most expressively within 1 month, they had the restoration of their symptoms and their epinephrine responses. Of course, they cannot regain their glucagon responses. Because of normal physiology and because of physiology in diabetes, the classification of hypoglycemia according to the new guidelines this year comes like this, that a level of below 70, just because of all this physiology, is a glucose alert value. You may treat it until it becomes 80, or this is a good value for adjustment of your anti-diabetic regimen. So it's an alert. But what is really clinically significant hypoglycemia is the level below 54 milligram per dl. Then you have to treat 15 grams of carbohydrates, wait for 15 minutes, another 15 till you reach the level of 80, and then eat your proper food. And then you have severe hypoglycemia, where you don't have any specific glucose thresholds, and it's the hypoglycemia associated with severe cognitive impairment, require external assistance for recovery. And now I come to type 2 diabetes. Type 2 diabetes, upon its diagnosis, is supernormal. The big circle on top is the overproduction of catecholamines during hypoglycemia in a person with type 2 diabetes compared to a control. But as you treat them intensively and you bring them back to a normal hemoglobin A1C, they reduce their catecholamine and glucagon responses, and they become like the normal people. They are still not deficient, so don't be afraid of them. But if you treat them with insulin for a long time, then, as you see on top, they start diminishing their glucagon responses, and they diminish their epinephrine responses, and of course their symptoms of hypoglycemia. So if you take them all together, a person with type 2 diabetes more than 2 years on insulin treatment starts resembling with a type 1 diabetic at the diagnosis of its disease. But then we have to treat our type 2 diabetics intensively, because we have seen in most of the studies that we decrease microangiopathy. And that has a result, of course, an increase of all episodes of hypoglycemia, and moreover, an increase of severe hypoglycemia in these people. And as in type 1, even in type 2, the duration of diabetes is related to the severe episodes, severe hypoglycemia occurrence. Hypoglycemia is more often seen in people with sulfonylurea compared with other medications, but mostly on insulin compared to sulfonylurea. And among the anti-diabetic treatments, of course, you see more hypoglycemia in the people treated with sulfonylurea compared with all the other drugs. As for the insulins, the insulin treatment of diabetes, especially the type 2 diabetes, you see more hypoglycemia events in the people who with the pre-meal insulins only compared to the mixtures or the basal bolus insulin. But what lessons have we learned about hypo in people with type 2 diabetes? These are lessons that we learned from 24,000 patients on the intensive treatment studies. In all intensively treated studies, VADD, Accord, Advance, the intensive control was accompanied with an increase of severe hypoglycemia. Most importantly, what we learned from the Accord study is that those who are not well controlled and they are difficult to bring them down in good control are the ones who have more severe hypoglycemia episodes. Severe hypoglycemia is related to the duration of insulin treatment, the low GFR, the low estimated glomerular filtration rate, peripheral neuropathy, education beyond primary level, and the past severe hypoglycemia. Lower fasting serum glucose and higher glucose-related hemoglobin are significantly associated with the frequency. And of course, we have a U-shaped curve on our hemoglobin A1C in order to see if the person will have a severe hypoglycemia. So the difficult parts are the very high hemoglobin A1C and the very low, because they seem to have more hypoglycemic events. What are the consequences of severe hypoglycemia? They are both from the heart and the brain. In terms of the heart, they increase the risk of arrhythmias. They are accompanied by abnormal prolonged cardiac repolarization, and they lead to sudden death. In terms of progressing neuroglycopenia in the brain, they are accompanied with cognitive impairment, unusual behavior, seizures, coma, and brain death. This is an acute hypoglycemic study done in a person with type 2 diabetes, and you can see the prolongation of the QT interval in this hypoglycemia study. And these are studies where they measured autonomic cardiovascular function by baroreflex sensitivity, and you see that it is abnormal during a hypoglycemic event. The way hypoglycemia leads to these events is either through autonomic neuropathy and then CNS activation, high risk of arrhythmias and sudden death, or through autonomic neuropathy, hypoglycemia unawareness, more episodes of hypoglycemia, QT prolongation, arrhythmias, death, or don't forget the potassium levels, because hypoglycemia is accompanied by low potassium levels that may lead to arrhythmias and death. Moreover, the counterregulatory hormones secreted during hypoglycemia are the ones that may have an impact, a negative impact on the progress of myocardial ischemia, because epinephrines are the ones that may increase hematocrit and platelets. Then cortisol is the one that increases the leukocytes, and they have a negative impact on myocardial infarction. Severe hypoglycemia, as we have seen in the studies, is accompanied by high mortality. And does it impair cognitive function? It doesn't seem to impair cognitive function in people who have normal cognitive function. But be careful, the people who have cognitive impairment before you start an intensive treatment, they are the ones that you shouldn't start an intensive treatment, because you should be afraid of hypoglycemia, because then it will be even worse and they may even lead to dementia. And this is why the lessons we learned from all the studies led ADA and EASD to talk about personalization of insulin treatment, and you have to take in account when you see a patient, you have to take in account whether he has many hypoglycemias or not, so to relax his treatment. What do you do to prevent hypoglycemia? In terms of oral anti-diabetic treatments, prefer the DPP-4 inhibitors, the GLP analogs, the SGLT2 inhibitors, and the metformin versus sulfonylureas. And these are studies that were done with the same design that I showed you on the first slide. GLP was introduced in these people, and you see the people who got the GLP sub-Q, they had greater glucagon responses during hypoglycemia. And these are studies done after an oral glucose tolerance test. So a DPP-4 inhibitor suppressed glucagon during the OGTT, but then it increased the glucagon during hypoglycemia. And here you see that you don't see any severe hypoglycemia episodes when you combine insulin with the DPP-4 inhibitors. As for the insulin treatment, prefer the basal insulins along with GLP, or the basal bolus treatment, and not the premixed insulins. Among the insulins that we have available, prefer the analogs, because all the studies, the meta-analysis of the studies have shown that the analogs, both short-acting and basal insulins, are accompanied with less hypoglycemia. Actually, 30% lower hypoglycemia and nocturnal hypoglycemia with the basal analogs, and with the short-acting, you have 40% reduction of nocturnal hypoglycemia. In terms of mode of treatment, of course, the pumps are doing better than the multiple insulin injections. And we have to consider the continuous glucose monitoring, because the continuous glucose monitoring brings warnings of hypoglycemia, prediction of hypoglycemia, and it's accompanied by automated insulin delivery. And these are the personal CGMs that the people wear, and they can read and see their blood glucose values every 5 minutes. They have trends and graphs and arrows and alerts. So they alert the person about the coming hypoglycemia, and they offer education and motivation to the patient. Using the CGM in people with multiple insulin injections or insulin pumps has helped to not only to decrease hemoglobin A1C, but also to reduce severe hypoglycemia over a period of 1 year. While using the continuous glucose monitoring along with the new pumps, you have safety overnight because the automatic suspension of the insulin delivery at a level that you have already set to the pump stop at the 70. That means that the pump stops at the 70 milligram per DL, stops for 2 hours, and then restores insulin from the pump after 2 hours if the blood glucose is normal. If not, it remains stopped for a longer time. Using these pumps, we have seen 30% lower number of events of hypoglycemia, 40% lower severity and duration of nocturnal events, and most importantly, 0 severe hypoglycemia and 60% lower nocturnal time in hypo. And the latest model available, I don't know if it is available in your country, is the prediction low glucose pump, where this is magic. I mean, it's the first step before the artificial pancreas. The pump stops infusing insulin when there is a trend of the blood glucose to fall from 150 milligram per DL to 70 milligram per DL within 30 minutes, and then restores insulin secretion. But don't forget education. You cannot do much with technology if you are not using education. And actually, the UK Daphne experience is great, and I would tell you, go to the internet and find the educational program, because 5 days course for patients with hemoglobin A1C around 7.5 in a 1-year follow-up had a result of restoration of hypoawareness at a level of above 58 in 43% of the patients, and avoidance of severe hypoglycemia in 30% of the patients. What you can do in your practice, you have to identify the persons with hypoawareness. And you can do it very easily with a history of hypoglycemia when they come to your office. Ask them how often they have hypoglycemia, if they get nocturnal hypoglycemia, how many episodes of severe hypoglycemia, if they're aware or unaware. Check their symptoms. Ask them about exercise, alcohol, and insulin doses. Ask them about how often they monitor their blood glucose levels, and also find out from their history if there are factors leading to severe hypoglycemia. I mean, if they're old, or if they have long diabetes duration, if they have renal impairment, or if they have lost weight during the last period. And I would advise you to offer even these simple questionnaires, the Clark and Gold questionnaire, that you can have it in your office, and if you get a result of over 4, that means that your persons are unaware, and this is how we found out that 25% of our people with diabetes, type 1 diabetes, have hypoglycemia and awareness. So it's education, technology, and last comes transplantation. Actually, transplantation is the only indication for transplantation for people with diabetes is when they get many episodes of severe hypoglycemia, and actually it is restored. And don't forget that technology has come to a point that the first artificial hybrid artificial pancreas got approved by the FDA September of 2016, just by the safety study where there was no hypoglycemia and no severe hypoglycemia observed and no ketoacidosis. Up to the day that we'll have the artificial pancreas available in our hands for everyday use, then we should go slowly through the algorithm that Pratik Chaudhary, who is coming to give a talk tomorrow, has proposed. So if you have patients with more than 2 episodes of severe hypoglycemia or a Clark score above 4, then the first thing is educate them and start them with analogs. The BGAT is an educational program that he proposes. If they still have hypoglycemia and more episodes of severe hypoglycemia, put them on a pump with a real-time CGM. And if that's not efficient, then the last step will be to put him on a pump with predictive low glucose levels. But don't forget, educational programs should be assigned at any moment. So that is my conclusion for how to treat and prevent hypoglycemia and severe hypoglycemia, and be cautious about any blood glucose levels around 60 milligrams per dl. Thank you.
Thank you very much for your very elegant, and you are just on time. Thank you.
For more questions? Okay, Dr.